Just a little bit.
Okay.
We just years. Okay, we're back. Senate Health and Welfare. Good morning. And we have with us members of the Department of Financial Regulation. So why don't you introduce yourselves for the record? And then we would love to hear your testimony, and there will definitely be questions.
I'm Mary Blunt, the Deputy Commissioner of Insurance for the Department of Financial Commission.
And I'm Kai Sampson, Commissioner of Insurance for DNR.
And we should go around and introduce ourselves. I know you've been here before, but we have new members, and I don't know that you're know them all.
I just got appointed, Orleans District.
Okay. Name?
John Morley.
John, I'm not seeing.
I'm John Benson from the Orange District.
Okay.
Jenny Lyons, Chittenden Southeast.
Martina Rock Hewitt, Chittenden Central, I live in Burlington.
And Cummings.
Hello
I've
again.
been answering several of you.
Yes.
Secret
Yeah.
this deja vu all over again.
Yeah.
Yeah.
So, yeah, we're asked to testify, I think, on Act 68. We had a piece of that, a report to talk about domestic health insurer solvency and how to sustain that. Obviously, when we say domestic health insurer, we mean Blue Cross Blue Shield of Vermont, which is the only one. And so we've done this visit to HROC, House Health, and also appropriations, which was my first time in appropriations, not discussing a budget. So, but
That was cool.
honored by the interest. It's obviously a very important topic. And I think, the compulsion in the statute for us to do a report on it really comes about because of some very scary financial challenges that Blue Cross Blue Shield of Vermont faces. They are a unique entity. They're a single state nonprofit entity enabled by statute, chapters 123 and 125. So in some regards, they are a creature of the state, enabled by that statute. Again, because they only do business in Vermont, and because they're a nonprofit, diversity of business and policies that many other insurers enjoy that help kind of weather the storm. Of course, insurance is all about spreading risk. Blue Cross has less of that opportunity as a single state entity. And also as a nonprofit, they can't do a stock sale to raise money. They're somewhat constrained in that regard.
So, and I'll just say that as part of Act 68, obviously, we worked very hard last year understanding how we could help and influence improving solvency for Blue Cross and Blue Shield, and work collaboratively with DFR. We're glad we did it. And then understanding that some of the contracts that are negotiated with providers in DFR were not transparent.
Mhm.
And then looking to see what are the things that are most helpful, both to you and to us, in terms of opening up both transparency, but making suggestions about how we can avoid. What did we learn? I got some.
Yeah, lessons learned for sure, is, and I think it's taken different people, since the ACA and the dissolution of BISHCA, that, I had a prior life in BISHCA on the insurance side, banking, insurance, securities, healthcare administration, then came, the single payer push, rate authority was moved, and the Green Mountain Care Board was created and took rate authority. I believe we're the only state in the US that rate authority is separate from solvency regulation. So, that is an awkward model to be responsible from a regulatory point of view for the solvency of an entity, of an insurer, but have no control over the primary way that they make money or break even, which is rates, adequate premium. So the real takeaway, I think, is you cannot regulate health insurance or healthcare affordability by suppressing rates. You have to address the cost of care. What I think, is challenged in many other states, and frankly hasn't been as much of a challenge in Vermont, because there's been a lot of pressure on, that challenge being that you do have in other markets and in other states, you have the insurer's profit being a big piece of the affordability challenge. That has not been the case in Vermont. We have a fairly, given their small size, a fairly efficiently run from an administrative cost perspective entity. Blue Cross Blue Shield of Vermont, their administrative rates are competitive with their competitors, of which we say were more, but certainly on the exchange it's just MVP. But even in the self-insured space, where you're very directly competing on administrative cost, they do well. So in Vermont, we actually have the opposite situation where, and I hope this was forwarded by Joe to the committee assistant. And so comes from an actuarial opinion. It's public information, but it's got two great charts in it. And it shows, with the qualified health plan since inception in 2014, that Blue Cross Blue Shield has cumulatively, this is giving the years they made money and then subtracting the years they didn't. They have a cumulative contribution to reserve or profit of negative 2.2%, meaning for every $1,000 premium cumulatively over the last 10 years, 11 years, I think, on this exhibit, they've lost $22. If I said $1,000 anyway. So cumulatively, that's 82 or 84 million lost. Again, that's the plus years and then the minus years together, not just the loss years, but in this line of business, they've lost a lot of money. They lost. Go ahead.
I'm just looking at 2023. I'm wondering if you're going to give an idea of why that is so great.
Sure.
Yeah.
Yep.
Yeah.
I can get there.
Okay.
So yeah, and cumulatively that 80 plus million in losses on that line of business is not insignificant for Blue Cross Blue Shield. In terms of, I think what you heard from Nolan about risk-based capital, in terms of why that's necessary and how that computation, which is a 50 state accepted computation, it's very sensitive to type of business, type of risk, something we put a lot of weight in insurance regulation of all types of insurance. They need that kind of denominator for risk-based capital. What should that denominator be in that calculation? It's very much driven by fully insured policies. So the easiest way for a company to show really great risk-based capital is to stop writing business, sit on their surplus without a lot of risk. So that the calculation is very sensitive to what we call underwriting or insurance risk. And the reason I bring that up is the single largest source of risk and weight in that risk-based capital calculation for Blue Cross Blue Shield is their fully insured QHP, small group and individual. They have some large group stuff, but that is the single source of need for capital. And it makes a lot of sense if you think about insurer that's charging you however much per month, no matter what your claims are, no matter what, horrible diseases you get and pharmaceuticals you get diagnosed with and need, they're on the hook. Whereas with a self-insured plan that most employers have, the state has, the employer itself absorbs the majority of that claims volatility. This is a relatively small pool between small group and individual, and Blue Cross is in insurance jargon, they're on the risk. So they suffer the slings and arrows of claims and cost. So that need for surplus is acute in the fully insured lines of business, again, which is mostly the QHP, qualified health plan exchange, those markets where they lost all this money. So that the emphasis I put there is because a huge contributor to their financial challenges has been inadequate rate, has been this tension between delivering affordable rates and the regulatory pressure to lower their rate for affordability. But in doing so, those results in the exhibit, I've sent and I'm referencing have missed the mark a little bit. Another way to look at these cumulative losses and the cumulative negative 2%, which is not, I don't say this to be cute, but it's just factual that as horrible and expensive as health insurance rates are in this state, they've been getting a bit of a discount. Consumers have been, can you believe that? They have been inadequate to pay actual claims cumulatively. And that's a very sobering fact. And certainly for a solvency regulator, a concerning fact. So adequacy of rates is critical. In terms of your question on 2023, these years of loss, those came on kind of steadily. They were detected early on.
Looks like 22 through 24 were pretty serious.
Yeah, and in the report, in the Act 68 report, you can see a chart that shows that decline. And both the company, Blue Cross, and the department looked into that claim surge, like heavy data analytics to see, is there a smoking gun? And there really wasn't. Okay, it was broad-based. There is a higher trend of growth over those years in claims growth from the UVM Health Network hospitals than the other providers, but not so dramatically high that you could say that's it. But that's the one kind of takeaway. Did you have any other takeaways in terms of that? Mary was there. I was blissfully doing internal audit at National Life.
No, I mean, I think it's a combination of things. We did look at claims trend and utilization, and it is, it's up across the board. I mean, part of it is probably pandemic fallout, right? Starting in 22, people started returning to the doctor. People started dealing with issues that came up during the pandemic, and then they couldn't get in to see doctors and so forth. But it just kept escalating. So we literally could not find one thing to come to. It is higher claims, it's higher costs, it is higher utilization. But there's no.
Yeah, I was going to go
one source.
overutilization and using high cost services, overutilizing high cost services, or
That's part of it.
Yeah.
It's not. Not.
But certainly when you have a high cost structure, which we do in the state in terms of cost per code or service, you're more sensitive to higher utilization all of a sudden.
Right.
That if when you're estimating rates, if you're Blue Cross and then the care board hires an actuary to do a third party review of what Blue Cross has filed, you're essentially saying, are the administrative costs fair, accurate based on the actual cost of the company? Is the contribution to reserve, which you see is in this exhibit as well, that what was filed for, I believe, yes, what was filed for and what was provided, is that reasonable given the financial situation, or is it profiteering? Is it too much profit in the rate? But the biggest piece, call it 90 cents on the dollar, is cost of care and it's volume and price, cost of care and utilization. And when you estimate each based on your contracting with the major providers, and I'll get into that. But utilization is based on history and outside factors that you're considering. And when price is that high, if your utilization estimate is off a little bit, it can cost you a lot.
I'm sure you thought about this, but it just seems like if people were delaying care during COVID and then they came out of the fog of the pandemic and went to the doctor, they had like delayed care, so probably exacerbated their illnesses, and then suddenly you had more people showing up. Seems like it was a,
perfect storm.
perfect storm. Yeah.
Right. Well, but the 20 million in 2020. So there's that good year, and then
But that's because
it hits.
So nobody went to the doctor.
We weren't allowed to.
And the wind starts blowing.
Yeah.
Yeah.
So in terms of contract, I want to talk a little bit more about what we've done in response to both the challenges as Blue Cross, as RBC went low. And make no mistake, if it were not for the Blue Cross Blue Shield of Michigan affiliation and the financial assistance through a loan that Michigan was able to provide, we would have been at an even think no one probably went through the levels of regulatory action based on RBC. And, you know, we hit the first one because of that loan, would have been in that second or even third level of regulatory involvement absent that loan. So that was very crucial. So the first thing that happens when they hit that, first of all, the constant communication between Blue Cross and Mary's team, and I was here. We got them on a corrective action plan per the statute before the filed RBC. You know, it's technically filed RBC is annual confidential filing. And, but Blue Cross essentially said, we're in trouble. And we said, we need an action plan. They provided one approved by the department before the year at RBC, and that loan was part of the action plan, to get on solid footing. Then they, you know, there was deep digging into the source of the claims surge, that we've discussed. They hired a contractor. We hired a contractor. Again, no smoking guns coming out of that. I think Blue Cross put together a kind of a task force. I'm going to use the wrong terms. The claims review, a new method for like claims review to get more timely and insightful data as claims happen. That serves on whether or not there's a search. More recently, of course, we did an order this summer to compel them to check in with us before signing any 2026 provider contracts with major providers. So I think the order itself references major hospitals. And that before we approve them executing that, and that's where the price comes from, right? Price times utilization. The price, think about 50% of of their non-pharmacy claims come from the hospitals, about 30-something% from the health network. So we were focused on that contract for 2026. And we said, do not sign that until you can show that deliver savings, both for affordability, but also for predictability in their solvency.
I think they signed it recently.
It's close.
It's close.
It's what were they say in labor negotiations? I think tentative agreement. But we're better. No, and so we kind of followed the model that the care board had of appointing a liaison. Care board had appointed the liaison, Mike Smith, and the team to the hospital, to UVM Health Network, and we wanted one to. But no, we thought that was an appropriate model.
Yeah.
And so we were able to find someone out of Massachusetts who could work on a contracting basis for the department with very deep and wide experience in provider contracting, total cost of care contracts, value-based care contracts. And I really think in addition to being eyes in the negotiation process for the department, I believe he has also added value to the contracting for both parties in terms of his experience. The UVM contract is close to being executed, I believe. But that was really necessary from my point of view, because I did have conversations with both parties in that negotiation over the summer. And at times it was just a he said, she said on real details of, you know, what's the will, the desire, and the motivations. And I'm like, this is not, first of all, I'm not a healthcare policy expert. I'm a CPA, a finance expert. I'm a healthcare finance and healthcare financial reporting is my background as a regulator. You know, we found ourselves, and Mary's an attorney and she's a compliance expert, you know, and so, you know, you have many people at your disposal that sit in these chairs that are healthcare policy experts, you know, we are not. And so I think having that liaison there, he continues to work for us, was really important for us to say, I just want one source who works for the department to tell us what's going on and call balls and strikes a little bit where necessary. So I think that was one of the more significant positive steps that we were able to make as a department to be more proactive because those contracts drive a lot. They are an opportunity for the insurer to influence the cost of care, which is really our best route to affordability. It is not rate suppression. And you know, and that liaison's been positioned to help with that and help us understand it.
Thank you. So I know that you went through some of the recommendations from the Act 68 report when we had HR Rock, and I didn't know whether you would give us a brief look, because the issue of reinsurance will be coming up at some point. And then continuing with cost of care. So whether it's reference-based pricing or some capitation in all over the place, or global budgeting. And I know you've got some recommendations for premiums and so on. Do you mind going through some of that really briefly with us? That would be very helpful.
Oh,
I'm looking at page 3 of 6 of
Yeah.
your report. And just an overview. I think that's where you have your, and then it goes on to reinsurance.
yeah, I mean, so you mentioned reinsurance, and that's, you know, there's potential there. Again, depending on where CMS and the federal government is on this. But Indiva will be very involved in this too, a 1332 waiver. It's in 585, and also potentially an AHS bill to just authorize the pursuit of that waiver. That can be an area where you can kind of optimize things on exchange policies to lower the cost of insurance. I think outside of that, again, the takeaway for me, I mean, I joked in the department that this could have been a 2 cents report, that the way to sustain an insurer like Blue Cross's solvency is to provide adequate rating, period. It's that simple now, because, and really I joked about it because there are things an insurer can do to influence the cost of care, and we've ramped up our expectations of them for that. It's through the contracting process. That needs to be done hand in glove with the care board as they're regulating hospital budgets, and want to do so in a way that rationalizes the price a little bit without an undue degradation of quality and access to care. That's of course a challenge, as you know very well. But at the end of the day, we want to make sure that the insurers have the tools they need to appropriately limit costs, right? Nobody wants to hear no, whether it's through a prior authorization or a hospital or provider wants to be challenged on a claim. They just want to see patients and move on to the next thing. And if it, you know, but you will see some solutions or some middle road kind of partial reversals back on the level 11 or modifications to Act 111, right?
That's that right.
In 585. Right?
Tweaking, not reversal.
Tweaking.
Tweaking.
Because, you know, to the extent that we put an insurer in a position where they simply just have to write checks, and that's, I'm going to be hyperbolic here, but they can't be in a position where they just have to write checks, or they have no influence. We can't then expect them to lower insurance rates without feeling inadequate. On the extreme end, you could completely empower an insurer to just make life a living HE double hockey sticks for billers, providers, to the extent that care is compromised. You know, it's administratively burdensome, and no patient ever wants to do anything anymore because they get 15 letters of challenges from the insurer or whatever, same with providers. So somewhere in between there is
Magic.
magic, yes. And so we'll be discussing that in 585. And of course, that you know, the care board discusses that on the hospital end of things frequently in terms of delivery of care.
Well, and it all fits together. I mean, ultimately, you know, you need to look at utilization, cost for each service, how we're paying for it,
Geographically, what's provided where by
all of that,
yeah.
all of the above. And all you want is that insurance company to stay solid so they can make adequate decisions.
Yeah,
You get it?
Yeah, and I think, I don't know if, Nolan's testimony went into it. But it truly is not exaggerating to say it would be absolutely disastrous to this state to lose Blue Cross. Blue Shield.
Oh, we understand that. Oh,
Because they are the only game in town, and, although none of us should speculate, I think we probably should accept the fact that if Blue Cross was not the QHP market, MVP would have a real challenge staying there, and a real
Yes.
challenge.
Nolan did.
Okay,
He did.
thank you.
No, it's good to have it reinforced.
Yeah.
Right. But no one is perfect. So, I mean, I'm not talking about Nolan and you. I'm talking about Blue Cross and Blue Shield's not perfect. So
Right.
we do need to maintain our system of regulation and oversight.
Yeah,
Yeah.
and I think from our part, you'll also see in 585, also bias to influence, how they're governed. And
I said, yeah, no, the bill went into the house and we don't have a companion over here. She's just.
right, but essentially, you know, I've provided an exhibit of losses on the, exchange cumulatively. Those losses are in part due to, reductions in their contribution to reserve and reductions in their medical trend, by the rate regulators, but they're also just misses in terms of, estimating what utilization. I mean, it is the responsibility of the insurer to have foreseen as much as possible some of these more dramatic loss years, right? So even without the reductions in the rate for those years, those would have been loss years. So it's not entirely rate suppression, but it's overall cost of care in the state, utilization. It is true, and you know, that they lost cumulatively about $50 million, from inception to, leaving the market in Medicare Advantage. That is an area that has challenged insurers nationwide. It's an area where state regulators have next to no influence on the rate.
That is a question that I've been wanting to ask, and so I'm glad you brought it up. And that is, what percentage of loss was due to the sort of the benefit that folks were receiving from Medicare Advantage, the risk that was applied to Medicare Advantage? I mean, obviously, it must have been charging too little, but the coverage they were given.
Yeah,
I don't know.
do you have a response to that? And again, it's pretty
Yeah, so
non-transparent for us in terms of CMS.
it is very non. CMS sets the rate. Medicare
Yeah,
Advantage, they have
exactly.
absolutely no control.
Just like
no-
with UHC.
You sound like me responding to my constituents.
Right.
Well, I mean, it's true, and it's something that we talk about as regulators across the country, because like that lack of control is very frustrating for
Yeah.
insurance regulators, right? But you know, it's our understanding from talking to the insurers, from talking to other regulators, that the rate that CMS has been setting has not been enough to sustain the marketplace. And so insurers all over the country have been losing money, pulling out of markets. You know, some of the big insurers pulled out of most markets. Some of the hospitals have refused to accept Medicare Advantage payments because they're too low. So this is all a function of sort of what happens at the federal government. We have no control over it. We have no control over the advertising, which we've been trying to get back from them as well. So we have no control over Joe Namath and his promises that he makes on the
I
TV.
know, it's frustrating.
We would love better control over what Joe's saying out there.
This year.
No, he wasn't.
No, we haven't seen him recently. right?
Yeah,
Yeah.
well, I mean, no joke aside, I mean, that could very well be that insurers are like, oh, wait a minute, we're not making money on this anymore.
Yeah, we don't want to.
Yeah,
Now,
Yeah.
they have two ladies that just can't believe that you can get all this,
all this for free.
no payment for a month.
Yes, and every year I have this conversation with my mother-in-law about what she's not really gonna get for free.
You know, I think in financial regulation, not just in insurance, but securities and, you know, that adage that there's no such thing as a free lunch. You know, that's probably the number one.
Free
consumer
healthcare is
protection.
what everyone wants.
It is.
There's no free healthcare.
But even that would have a, you know, cost somewhere. Someone's
Yeah.
bearing the cost somewhere or shortchanging you somewhere. I mean, at the end of the day, I do believe that is a very true statement.
But yes, the marketplace is terrible. I mean, MVP And well care, I think, pulled out last year for the same reasons. This year it was
Right.
HC and Blue Cross. Blue Cross was kind enough to tell us ahead of time. They don't have to. Kind enough, Care did not. We found out at the same time everybody else found out because we have no control over that. And so we get no notification.
So I know there are a number of folks I represent, I mean, do meetings in various communities and, so there are people who've had Medicare Advantage for years and they retired onto it. They love it. Now, have they lost those as well, or is it idiosyncratic? Okay.
Now, anybody who had Medicare Advantage through Blue Cross or UHC lost their ability to have Medicare policy this year, Medicare Advantage policy. The only Medicare Advantage issuer in our marketplace now is Humana, and they are not in all counties. They're in 6 counties.
Right, that's right.
At this point,
Not the big ones.
and not the big ones. They are in Orange County. I know.
Okay,
But they, so they have a very limited footprint. And so everybody, for the most part, had to either switch back to standard original Medicare or to buy a Medicare supplement plan, which is more expensive. And so people had to make that choice this enrollment period. And there was a lot of chaos. The ship took thousands of phone calls, phone calls, the healthcare advocate's office took phone calls, trying to help people navigate what their rights were, what their options were and so forth.
oh, yeah.
No,
The only, silver lining that's not even that silver is that, by having plan not offered anymore, you get re-enrollment,
Right,
ability
goes to March.
as back, the similar choices to you had when you originally enrolled, whereas absent losing your Medicare Advantage plan, you're kind of stuck in Medicare Advantage. And it is a plan that doesn't work for everyone. It's a plan that really delivers great benefit for folks that fit the right health profile. But for others, they realize where the free lunch was coming from in other benefit reductions.
it's a free lunch.
And that's a one-way street. So what the only kind of silver lining to this was that it opened up the one-way street for those who wanted to turn around.
Wanted to get out of it.
Yeah.
But yeah, the cost shock is very real and universally just, and
And that's relates to the cost of healthcare.
yeah, and I think those nationwide
Right
issues that everyone saw in the Medicare Advantage was pretty widespread in Medicare Advantage. Of course, we're more acute in Vermont because we didn't have a lot of players. We have and a high cost of care here, so all those issues hit kind of harder, faster here.
Other questions? Do you maintain a relationship with CMS?
We try.
And do you have any relationship with regard to, I'm ignoring that, with regard to, sort of the prescription drug part D and the penalties that people pay and all of those things? No, it's
Another
hard to have an influence.
Yeah.
We don't have that influence, do we, as a state?
Yeah, we try to use, the National Association of Insurance Commissioners, NAIC.
Oh, yeah.
Regularly comments, testifies.
Yeah.
We try to use that organization to sort of push those agendas because it's a little bit more critical mass in the state of Vermont, although we do, file comment letters and things like that when we can. So when it makes sense for us to do so, we do comment on the proposals and things like that, even if it's just another voice to add to the file.
Well, thank you. I know that a couple of our team are gonna leave very shortly but I appreciate your coming in because this sort of supports what Nolan was telling us about, but it's from your perspective as regulators and it's important to hear. This is not the last time you'll be here, I think, and I'm definitely not the last time you'll be in Senator Cummings' committee.
Right.
Maybe,
I never got confirmed, but so I don't know if that can still happen. But
Really?
wouldn't it? Yeah. Well, because I started in April.
I said that the other day, I think. No, I haven't got a confirmation letter.
Oh, okay. Who's that come from?
The governor.
Okay,
You should mention that to him.
Yeah, I'll mention too.
You would have, we
Maybe
need a
some-
tax commissioner like
Maybe I'm
that.
still on probation.
Get through
They
everybody
would be
paycheck.
coming. We
Yeah.
have you in for an interview.
Oh, okay.
And I will double check with Charlotte, but to the best of my knowledge, it hasn't been submitted.
Okay.
Maybe
Well,
maybe you should check on that.
Get it down and we'll get it done.
Yeah.
Tell
So-
them to send contact information too. We always, they send us a thing
Oh,
and
well, you don't
no
have-
way to.
Yeah.
To reach people
Yeah.
to, for you, we know where to find you.
Right.
Or
Yeah,
most
as a general
parts.
rule, yeah,
as a general,
okay.
that's one of the things that.
Thank you.
Thank you.
Thank you very much.
Yeah,
I
nice to meet
really
you.
appreciate it. It's good. So we've got about 5 minutes and I'm gonna ask Blue Cross and Blue Shield if there are comments. And you could come up and just give us a quick introduction to you and then. There.
And I will be brief.
Because we will have more formal.
Thank you. For the record, Courtney Harness, Blue Cross and Blue Shield of Vermont. Thank you. And I do have notes, for the committee. Our CFO Ruth Green did testify in House Healthcare on January 9th. I will email, her full written testimony to Callista for the
Good.
committee.
That's good.
In the interest of being brief. So I do want to just mention first, thanks to JFO and to DFR for their testimony this morning. Both, I think, reflect real financial pressure that Blue Cross of Vermont has experienced. And it's important to us that we do acknowledge that directly and understand that our financial condition doesn't just matter materially to our members, but Nolan and Commissioner Sampson both mentioned essentially to the entire healthcare ecosystem of the state of Vermont. And so there was some pretty sobering financial news in their testimony. And so I do want to just share some high level updates as there were questions. 2025 results, although not final and year to date through September, we have realized a $47 million gain. And that was in contrast to a loss that was in the $20 million range, 29 million maybe through the same period of 2024. And we do expect that our fourth quarter numbers are tracking similar number of factors weigh in, particularly in the month of December, that we'll need to let play out. And I will mention, typically while we're all on town meeting break in the first week of March is when we're preparing a more formal communication relative to our actual year-end financial results. And so some of that 47 million, and there was some commentary about the loan from Michigan. At this point, that has been fully repaid in the month of December in 2 separate installments in December. And so any of the financial progress that we've made relative to the corrective action plan with VFR would be representative of the repayment of that loan as well. I do want to mention in particular, of course, this does take work across all levels, including DFR and Commissioner Sampson was very right on it in bringing Green Mountain Care Board into the conversation, obviously a critical component of our rates. And Chair Lyons, you mentioned some of the legislation from last session and really, really important work that happened here to make sure that things happen. I also want to say part of our corrective action plan and some of the look that we do internally is what we do so that we're not always saying what legislation can you pass and what regulations can occur. And for us in 2025, that was a reduction in operating expenses of approximately $7 million compared to 2024. And so that's no small amount. That is material and took a lot of hard work for us to get to that number, and we're proud of the work that we did to reduce those operating expenses. I would say, as far as your role and what helped in particular, Act 55 and the pharmaceutical bill that passed, lowering rates by what we estimate the dollar amount of that to be, allowed us to offset about a 4% premium reduction, just from that legislation alone. And, I also want to mention a couple of other things that we did, and some of you have seen it. 2025, we did launch the Affordability Matters initiative, and it's been in the news recently, where we're really trying to help Vermonters better understand the relationship between healthcare prices, utilization premiums, and affordability. And we do believe that that reflects our responsibility to our members and to Vermonters, that there's a shared understanding of what drives some premium increases, and that being in particular cost of care. I would say, looking ahead to this year, and Commissioner Sampson did mention this, obviously continuing to work very closely with DFR and the entire team there, regular ongoing conversation, usually multiple times a week between some members of our teams, as well as the Green Mountain Care Board, and as well as not just this committee, also House Healthcare. And as you might imagine, I'm up there a great deal, and some of you may have met our new CEO, Beth Roberts, last week. She was in the building on Thursday, and we're very grateful for the time that some of you were able to spend with her. We do believe that Beth's experience, along with the partners with regulators and healthcare systems and legislators, really have us positioned well. I think the last thing that's really important, great progress in 2025, and we heard about a corrective action plan. We still have several years to go on that corrective action plan, and 1 year is 1 year. And while we're really proud of the work and the results that we've achieved, in particular for our members, it's important to know that there's a long game ahead of us on this, and there's no one piece that will fix it all. And I do it, like I said, there's more updates. I'll make sure Calista has them to pass along.
Thank you. Thank you for being available. This
Of
is
course.
really short notice for you, but this is a helpful sort of overview, and obviously you'll be back in. It might be good to have Beth Robertson just to share with
Sure.
the entire committee her background a little bit. She's got an interesting background. Questions? All right.
Thank you.
Thank you so much. Appreciate it. Thank you all. I understand that Green Mountain Care Board is robbing us of 2 members. Taking away for a little field trip. So we're gonna finish early today. Are there any other things that you'd like to put on the table, Senator?
I'm not sure if everybody got invited to the legislative breakfast at Gifford. I didn't make it. It might have been just legislators in this
I
area,
think it was.
but I had a really good conversation with Michael Costa.
He's gonna come in.
Good, that's what
My goal, let me share my goal with you, because the hospitals are working really hard right now, and they've made significant change and transformation. They're doing all the things that one could hope they do at an early stage. Some of it is low hanging fruit, and some of it is really greater depth. And I would like to have an opportunity for them to present to us and to the House Healthcare Committee, a joint meeting with us to have that, to share what they've done. It's very good. I had the great advantage of going to a meeting with the hospitals, couple of meetings with the hospitals in the fall, as I said before. So that's my goal. The House hasn't been as enthusiastic about doing that as I am. So regardless, we're going to do it somehow. And it may be a 3-committee process. We'll see, because it also involves other folks, human services. So just wanted to put that in. I appreciate your bringing up because Michael is one of the ones that is a star.
Yeah, I'm like cloning. I tried to convince him he should go
Cloning
into
is not
education, but it did not go.
We have to pass a law before we can clone him.
I know. Michael has a
Will
long
that be
history,
covered?
starting with our first mover act. He has
Okay.
been, he might have been here when you were here. And he is very good.
Yeah.
They don't have a primary care or a mental health waiting list anymore.
I know. It's huge.
Yeah.
It's huge. So with that good news, there's a little bit of good news within every bit of bad news. This is good news. So